guys are here, that means you guys really want to do endovascular. So this is going to be, if you guys are doing CTOs, this is going to be like a bread and butter CTO for you guys. So I'll just basically, okay. So a 64-year-old male patient, hypertensive, dyslipidemic, I don't know why it's moving like that. Okay. Smoker, typical claudican for us with all the risk factors. Severe left lower extremity claudication with the full class, category 3, persistent on cilastazole, aspirin, and pain medications. And exercise therapy, ABIs are clearly 0.76 on the right, 0.62 on the left. Arterial Doppler, as we discussed this morning, ABI first, arterial Doppler next to categorize your lesion, SFA chronic total occlusion, and my mouse is not working, guys. Okay. So we get access on the right side. In Sinai, this is a bread and butter CTO, so I'll go very quickly on it. We get always antegrade access. We always go from the other side. Most of the CTO lesions, at least most of the peripheral interventions, we try to do it from the femoral axis. We reserve pedal access only if it's necessary. That's our style at Sinai, and most of us who work here, we do it the same way. So let's go for that. So we cross up and over with our catheter. You can clearly see the SFA is diffuse diseased on the proximal end. And when you have diffuse disease like that, it's a total occlusion. You don't know where the stump is. Now you have to look for the reconstitution in the distal end, like you guys know. So we take a long cine, reconstitutes in the Hunter canal, which is a classic CTO case, right? Most of the times after the Hunter canal is where the reconstitution happens through the profunda, classic. Then we take the runoff. We always start, and I think you guys should too, always start with the foot chart and with the foot chart, always. Especially for claudicants, and again, CLI cases, they are compulsory anyways because you guys are working in the foot most of the time. But even for regular claudicants, you should always, no matter how simple the case is, no matter how complicated the case is, start with the foot chart and with the foot chart. Again, popliteal is pretty disease-free, just moderate diffuse disease. 3 vessels on the top, but again, we go to the foot chart. You can see anterior tibial kind of tapers down, posterior tibial tapers down. Peroneal is a dominant vessel. You can see the posterior tibial is a CTO. As we see the foot chart, peroneal comes down, gives collaterals to the posterior tibial going down to the foot. The anterior tibial is still diffusely diseased. So you technically have a 1 vessel runoff here. So that's where the challenge comes. Even though it's a straightforward CTO, the challenge comes is what you do. So before I go to the next picture, I think I'll pass the mic around. Any 2 of you guys, I just want to know, how do you guys want to proceed next? Anybody, doesn't matter. It's not a question and answer case. Just quickly. You have anybody? So let's start from this side. Go. How do you want to proceed next? Put the wire in, cross. Dr. Purushottam just gave, Dr. Bhaskar just gave a talk, right? Get the catheter in, form your loop if you can. This long of a CTO, it's very difficult to go luminal to luminal, right? I think at this point, again, you guys have to choose. If you want to be luminal to luminal, this is a good case. There's no calcification. So it's great to try 014 wire, then 018, then 035. If it's calcified, again, going luminal to luminal is not possible. So probably making a loop technique like Dr. Purushottam was just saying, forming a loop, shorter loops, try not to tear too much. The goal is not to tear across the collateralization. Don't stent. Try not to stent as much as possible across the collateral. Keep it clean. Make sure you enter before the collateral starts in. That's the goal. So when you do that, here we used a Confianza wire. We got through and through the lumen, especially because there was not much for calcification. We wanted to be luminal. The main reason is we didn't want to stent. So in Sinai, we have a policy, no stent policy. So we try not to stent as much as possible. All of us do. Sometimes we do end up stenting if you need it. So we cross lumen to luminal. Then we atherectomized it. You have 1 vessel runoff, so you have to put a filter. Even if you're atherectomizing, definitely put a filter. If it's calcified, definitely put a filter, even if you're ballooning it, because the risk of embolization is there even if you balloon a lesion. So I would put a filter, especially if it's 1 vessel runoff. That's the goal. take one point. So we crossed it, we atherectomized it, and let's see if we can.
You aspirate your CTO?
I'm sorry?
You aspirate the CTO?
No, we don't. Unless we think it's thrombotic, especially if it's instant. And I think there's a case coming up next. So I don't want to talk about that part more in detail. But yes, if it's instant, also if instant, if your wire just crosses the stent without any resistance, then we definitely think it's thrombotic. If you have a lot of resistance, you have to form a loop to tear across the stent, then yes, I would say thrombectomy doesn't make sense. You have to decide if it's instant, restenotic, or is it thrombotic. I think Dr. Krishna.
So Dr. Gujja, you said atherectomy, balloon, stent, filter. So how do you justify the cost if you're going to use that in all CTOs? Is that an algorithm you follow for every single CTO?
Yeah.
Are there markers of when you use a filter, when you don't, and how do you decide on what device to use based on what?
Yeah, I think Dr. Krishnan asked a great question. We are Sinai, we can use whatever we want. I'm just kidding. Sorry. It's funny that Dr. Krishnan asked the question. So I'm just saying, that's a good question. So we have an algorithm. We actually published a paper for that algorithm. I think that's why Dr. Krishnan is particularly bringing it up. It's great. So when to use the filter, when to use what kind of device. So we use a filter for any one vessel runoff. If it's a long CTO, it's a no given, we will use a filter. If you're atherectomizing or ballooning it, if it's calcified. If it's a two vessel runoff and you're not using an atherectomy device, you do not have to use a filter. You can get away without putting a filter if you're ballooning and stenting it. If it's three vessel runoff, it's your choice to do. How aggressive you're going to be with the atherectomy. We are very aggressive with our atherectomies. So if it's anything more than two vessels, if it's two or one vessel, we definitely put a filter in. Three vessel, depending on the size of the lesion. If it's a long segment CTO, we do, because the amount of atherectomy we do. If it's a short segment CTO, you really don't have to put a filter in. It's a choice you make on that, of what you're going to do. Balloon stent, atherectomize it. Most of the times when you atherectomize a long segment lesion, I would recommend putting a filter. It just saves time for you. Yes, the cost is there when you're doing these cases, but I think for the amount of reimbursement you have, I think it's okay to pick up that cost for the filter, because it saves a lot of time, especially for you and for the patient. You don't lose any vessels or anything. Dr. Krishnan, good?
Yeah. Does the choice of atherectomy affect you using filter or not? Like directional?
Yes, it does. So I get this question a lot. I don't think it matters. It depends on the amount of time you're going to atherectomize, how aggressively you're atherectomize, and your purpose of atherectomy. Some people do atherectomize to call lesion modification. Some people atherectomize to get a good luminal gain. So it depends on the reason of your atherectomy. If you're atherectomizing just to get a lesion modification so that you can balloon stent it, then no. But if you're atherectomizing like us, we do it to get luminal gain, because we want to do a DCB. We want to get as much luminal gain as possible. So we use a larger devices. When using large 6 French, 7 French devices, yes, I would say debulking, you should use a filter, because you're going to embolize. Doesn't matter what kind of device you use, you're going to embolize. And the device depends on you guys. We have our choices, you will have yours.
So
Right.
Just for the fellows, the filter use is very controversial because if you ask a lot of very talented operators around the country, they'll tell you don't use filters because they don't use filters. But I think what's important for all of you to remember is that it's the time that you spend on the case and how you're going to bail yourself out. So if you believe there's a high risk of embolization, either in the morphology of the plaque when you cross the lesion, or in the nature of the presentation. If the patient presented with, say, subacute symptoms, 2 to 3 weeks, maybe a thrombotic event occurred that was probably narrowed and then is underlying thrombus, so you might embolize. So it's very important because the cost is important. Second, could you comment on what filters and how you choose your filter?
All right. So there are a couple of filters which are approved. There are a couple of which are not FDA approved. So
Actually, no.
now both the filters are.
Correct.
Yes, that's true. So initially, Medtronic had a spider filter, which was approved from the beginning, but now Abbott has an Emboshield filter, which is approved now. I think which just happened last year, if I'm not wrong. Right? Yes. Okay. So it depends on what you're comfortable with. There are two filters, again, because Dr. Krishna brought it up. So I'll talk about it. So you have the advantage with, both have their own advantages and disadvantages. One is spider could be a large device. So if you're using a 7.0 spider or a 6.0 spider, then you get a lot of protection, but the wire is not independent of the filter. So if you're not careful, if you're not a good wire management guy, it depends on you. You have to choose it. If you think that your wire moves a lot when you're getting in and out of the devices, then spider is not your filter, because it's going to move, because the wire is dependent on the filter is dependent on the wire. If you think like your wire moves a lot, but you don't want a large device in the popliteal, and you want just minimal protection, or if you want to get, you're not atherectomizing a lot, then EmboShield is a great device, because the filter wire is completely independent of the filter itself. So no matter how much your wire moves, your filter is not going to move from the position.
Right.
So that's the goal.
So they have a question. Okay.
Yeah.
Using a filter with an atherectomy device, does that mean that you're limited to using the Medtronic device, or can you use something like the CSI? CSI requires a micro-wire.
Okay.
Can you use different wires? Or
So the question is, does using the device limit the kind of device you're going to use?
Using
Yes.
a filter, yeah.
So if you're using a Medtronic device, you can't use anything which is a rotational atherectomy device, like a CSI or something, because you can't use CSI over a Medtronic device. You can use a Silverhawk device, any directional atherectomy device, you can use it. I think even Philips device, you can use it. But if you're using a CSI, then EmboShield is a better thing, because you can put your overnight wiper wire down on the filter on top of it, and then you can use your CSI very clearly. Because bare wire is almost like we can change the bare wire to own wire, if I'm not wrong, Dr. Kwan.
Right. So the EmboShield gives you an option of
Yeah.
changing to if you're a CSI operator, you could exchange your EmboShield wire, the native bare wire, for a wiper wire. They come in with a tapered segment so that the filter doesn't fly off, and you have the distal edge being 017 and the proximal is still an 014 working length.
You just have to make sure that when you switch to a bare wire or something, or when you use a wiper wire, make sure the tip is 018. If it's 014, when you get your wire up, the filter will be independent of the wire. It'll just move
And
across
we have
the filter.
simulators.
So Karthik, I think there's a filter workshop for the
Correct.
fellows.
Yes.
And so you can play with both the Abbott as well as the Medtronic filter as well during the workshop.
As I said again, I think it depends on you guys. You guys have to pick that choice. There's a lot of the biggest thing and the best thing about endovascular is there's so much armamentarium we have right now in our toolbox. So you can pick whatever you want, what you're comfortable with. So again, here we atherectomized. I'll just skip to the end. We DCB'd it. We got a clean result because we were lumen to luminal. So very minimal dissection planes, but you have DCBs, so you can get away with it. Again, clean. We used a Medtronic device here, again, Silverhawk, because I wanted a good luminal gain. So we got what we achieved here. I was almost after every single case, if it's a CTO, if we feel like there's a dissection plane because you don't want to leave anything, definitely you don't want to leave a significant flow limiting dissection plane because you worked all that hard, put the filter in, put the devices in, and if you leave something which is going to restenose in 6 months, then it's not worth it. So you have to make that call what is necessary. Again, we end up with a foot short. This is very, very important for fellows. You get into a habit of doing it, you have to do it. And it'll really, if you are doing endovascular, then this is a good kind of a thing to do.
All right. Good. Awesome.